Uh, Good morning to all. So, continuing with the gastroenterology classes, last time we discussed about the basics of the gastroenterology and what topics I am going to deal in my lectures. I gave an outline what are the various organs in the gastroenterology alimentary tract system, what is their function, how they secrete the various hormones and enzymes, and as a result of all these things you whichever food you ingest and you are able to digest assimilate it, digest it, absorption take place in the small intestine and all these things, right? And the water absorption take place in the large colon, and as a result of which the waste material is eliminated through the feces. So that was the outline of the my subject. Now continuing further, now today we are going to discuss about the GI investigation. What what uh, what kind of the investigations in a gastroenterology system which we often perform for the diagnosis and management of the patients. We are going to discuss it right now. And the GI investigations are basically of two or three types. One is the non-invasive, and the non-invasive investigation includes the plain X-ray abdomen. I will subsequently I will explain one by one the utility and fallacies of all these investigations. Right. So coming, firstly, we will discuss about the plain X-ray of the abdomen, then barium studies, ultrasonography. You all must be knowing that ultrasound is not new to anyone. Everybody knows about it. What is the utility of the ultrasound, especially when the abdominal conditions are concerned. Computed tomography, that is the CT scan, MRI. Everybody is well conversed with these entity nowadays, and the magnetic resource resonance cholangiopancreatography, that is the MRCP. So, and the whereas the invasive one includes that the upper GI endoscopy, lower GI endoscopy, because here you are doing doing the invasion in the cavity by the scopes, by the upper GI endoscopes or the lower GI endoscopes. Lower GI endoscopy includes two variants, that is the colonoscopy, what we call the full length colonoscopy, that is we are seeing the whole colon till the cecum, and sometimes we only need a limited, you can say limited colonoscopy, that is up to the sigmoid colon or something like that, and what we call the sigmoidoscopy. We are routinely doing all these procedures in our endoscopy suite in old OPDC block, and if you happen to be over there, then you are most welcome to see all of these procedures, that is the upper GI endoscopy, lower GI endoscopy, how we are performing all these things. Endoscopic retrograde cholangiopancreatography, ERCP, is there, enteroscopy, single or double balloon, and the wireless capsule endoscopy. These two entities, that is enteroscopy and wireless capsule endoscopy, I think they are beyond your scope. But just to remember that these are the entities which are pertaining to the gastrointestinal tract. That's why the term uh, should not be new to you. If somebody asks about these things, what is the enteroscopy and what is the wireless capsule endoscopy, uh, you just should know about it. Uh, Coming to the first invention, that is the plain X-ray abdomen. It is a very cheap, simple, easily available everywhere. In fact, in any PSC, CSC, even at the tehsil level, you can have the X-ray of the chest, X-ray of the abdomen, and it is of importance whenever you are dealing with the patient with acute abdomen. The patient is presenting with the acute, sudden onset pain abdomen, right? And the utility I will tell. It helps in differentiating the intestinal obstruction from the paralytic ileus. It is the, you can say, the first line investigation. If you are having a patient of the acute abdomen, if the underlying conditions, or if the history is, if by the history you are able to ascertain that the patient maybe has having some intestinal obstruction or some paralytic ileus, something like that, right? It has in differentiating at a first instance, right? As far as the diagnosis of intestinal perforation, yes, it is again made by the plain X-ray abdomen, because every time you cannot go for the CT scan to rule out the intestinal perforation, right? And the ultrasound is of no use as far as the plain X-ray, as far as the intestinal perforation is concerned. Possibility of position of the foreign body injection assessment. We see a lot of cases in day-to-day practices that the patients are coming with a foreign body injection, right? Sometimes mostly in the children, so 7 year, 8 year children, if they are playing at their home with their toys and all these things, they sometimes ingest this. batteries, this coin shaped batteries are there in most of the toys nowadays. It is not like the batteries which you put in your wall clocks. These are small coin like batteries are there, and we usually get all these patients in our day-to-day practice for the endoscopic assessment. And first of all, we always get the patient that we will do the plain X-ray of abdomen, right, and just to look for the position of the foreign body. If it has gone beyond the stomach and the duodenum, then there is no point that we should do the endoscopy, because we will not be able to retrieve. But yes, if by plain X-ray abdomen, if if we can be of if we are certain that it has been there in the esophagus, right at the lower end of the esophagus in the stomach. Hmm? A rough idea is being carried out by the plain X-ray abdomen, and if we are able to ascertain, then we usually take it out through our endoscopes, right? And they are the plain X-ray abdomen, especially whenever you are dealing with a case of intestinal obstruction, intestinal perforation, they are usually done in the standing and the supine position, right? See, uh, this is a classical description of the plain X-ray abdomen showing the intestinal obstruction versus ileus, right? Here, the intestinal obstruction, this is a standing view, right? Because in the lying down, all this fluid will be scattered, right? So you will not be able to see any such air fluid level. But as the this you can say, as the patient stands, the air fluid levels are there. This is the fluid part, right? Air is always black, right? Fine. So here you can see the multiple air fluids. This is one, two, three, four, five, six, seven, multiple. Almost 10 to 15 air fluid levels are there. In a normal patient, you will only be able to see only two or three. That is one in the stomach is always there. It is full of the fluid. So here it is a normal physiological process where you can see the air fluid levels, right? Otherwise you are not you will never be able to in a normal person, you will never be able to see this type of X-ray, right? If this type of X-ray patient presenting with the typical complaints, straightforward diagnosis is intestinal obstruction beyond doubt. On background of history, a patient always gives the history with this type of X-rays that patient is having the obstipation, that is the inability to pass the flatus and the feces, right? Patient has got the marked tense abdomen because of the marked air hunger. He's able to he ingests much of the air, but it is not able to uh, transit through the gut, and as a result of which all the air gets stasis, and as a result of which there occurs the air fluid level. This is the fluid, and this is the air, right? On the contrary, it is the it is the ileus, right? Ileus means that the intestine is, you can say, is in a transient obstruction. The whole of the intestine is in a transient obstruction, right? It is, there is no peristalsis, and as a result of which the whole of the intestine, right? Here you can see up to this one small intestine and all these peripheral parts. This one, they are all the large colon, right? Fine. And all of these things, they indicates that it is a ileus. There is no as such air fluid level in the ileus. The whole of the abdomen is full of gases because of the decreased peristalsis. It may be due to the hypokalemia, post-operative states, and multiple comorbidities are there in which the patient can have the paralytic ileus. You will come to see once you will deal all these things in your surgery lectures, right? But we often see these type of patients, right? If the patient has got the multiple air fluid, then there is some intestinal obstruction is there. There is small bowel obstruction, there is a large bowel obstruction, then we have to ascertain. But if the air is there till in the rectum or sigmoid colon, and whole